Good evening, everyone, and welcome. I'm Lori Castleman. I'm the founder and CEO of June Health, and I'm so pleased to welcome you all to the third session in the OTIP Women's Health webinar series. Tonight's session, From Fog to Focus, Protecting Cognitive and Brain Health During Menopause, focuses on a topic that we hear about quite often from women navigating midlife: changes in memory, focus, and cognitive clarity. So, we are really pleased to have you joining us for this very important conversation this evening. Before we begin, I just want to go quickly over a few housekeeping details. You'll notice on the slide that there is a QR code on our screen here for Wordly, which is the live translation tool that we're using to help make today's session accessible to everyone. Once you scan that QR code, you can select your preferred language for real-time translation and follow along with live captions or translated audio on your phone or device. It's really easy to use, so just scan the code and follow the prompts if you prefer to use an alternate language versus English. We'll also be leaving time at the end of the session today for Q&A, so please keep your questions in mind. Drop them in the Q&A box at the bottom of the screen as we go through the discussion today. If you'd like to have us aim, we'll see how time allows here. But if you'd like to have us aim to answer your question, please just pop it into the Q&A box. I will also mention that we received a large number of questions prior to tonight's session, so lots to cover when we do our rapid fire Q&A section. And finally, at the end of the webinar, you're going to see another QR code, which is a link to a short survey. So we would really appreciate if you take a minute to complete the survey. Your feedback really helps us to understand what information and support is the most valuable to you. And it also helps us shape future topics and sessions to ensure that we best serve the needs of our OTIP members. And now it's my pleasure to turn it over to Krista Gingrich, someone that I know many of you will already know, to share a few words from OTIP.
Thanks so much, Lori. Hello and good evening, everyone. So as Lori mentioned, my name is Krista Gingrich, and I'm a group benefits consultant here at OTIP. I'm so excited to welcome you back as we continue the OTIP Women's Health webinar series. This was created exclusively for OTIP members in partnership with June Health and Member RX. This series is all about empowering women with knowledge, connection, and the tools to support well-being through every stage of life. Our first two webinars were a great success. So they sparked meaningful conversations, they fostered connections, and shone a light on women's health topics that too often go unspoken. So thank you so much to everyone who joined us and helped to create such an engaged and supportive community. We truly value your feedback. So as Lori had mentioned, if you have a moment to complete the survey at the end of today's session, it would greatly be appreciated. So, as the series has unfolded, I've reflected a little bit on my own health journey. And after talking about nutrition, hormones, and daily habits in our past sessions, I started thinking about, how for many of us, menopause isn't just about the physical symptoms. It also affects how we think, how we focus, how we remember, and how we feel mentally sharp. So, understanding our brains, what's happening, and learning how to protect and support cognitive health can be incredibly empowering. So tonight, as Laurie mentioned, we are thrilled to introduce the third webinar in our series, From Fog to Focus, Protecting Cognitive and Brain Health During Menopause. Together, we'll explore how hormonal changes impact brain health, why cognitive symptoms are so common during this stage of life, and what practical steps can take to support clarity, focus, and long-term brain health. So women's health has long been surrounded by stigma, and through connection, education, and self-advocacy, we're changing that. So with that, I'm pleased to turn it back to Lori, who will introduce our speakers for this evening.
Thanks so much, Krista. Very much appreciated. Okay, so I'm really pleased to introduce our two speakers for tonight. The first is Dr. Rami Nitsch, who I know many of you who have joined previous sessions would be familiar with. Rami is my incredible co-founder here at June Health and our medical director. She is a deeply experienced women's health expert, OBGYN physician, and an incredible member of our team. Joining Rami tonight, we have Dr. Val Vorstenbach. Val is a clinical and counseling psychologist with a special interest in women's mental health and has a deep, deep level of experience in sleep therapy and sleep management as well. So we couldn't ask for two better experts to be leading tonight's session. And so, with that, Rami, I will turn it over to you to dive into our content tonight.
Thanks, everybody, for the great introduction. And I am thrilled, as is Val, to spend the next hour and a half chatting to you about cognitive health. There's been a huge uptake of research in this area as it pertains to women in midlife. So I'm optimistic that, we're going to have a greater recognition of some of the real cognitive health impacts that women experience. It also says a lot that we're invited to speak at OTIP. It really means that there's a huge value placed on women's health. So I want to start with a moment that many of you might recognize. You're in the middle of a lesson or doing something else at work. You've taught this topic for years. You know the material inside and out. A student raises their hand and asks a question, and suddenly the word you want, it just isn't there. You pause, you know the answer, you've said it 100 times before. But for a second, your brain feels like someone pulled the file out of the cabinet. You fill the silence, you say something like, it's on the tip of my tongue, just give me a second. Eventually it comes back. But later in the staff room, you start wondering, why did it happen? Am I just exhausted? Am I losing my edge? Am I losing my edge? And the truth is, for many experienced educators, that moment is not about burnout or aging or confidence. It's often perimenopause, menopause, or other portions of our reproductive health journey that are affecting brain function. And so today, we're going to talk about why your brain, sleep, work performance, and relationships change over your lifespan and what actually helps. I want everybody to play this little game for a minute. I want you to read the slides quickly to yourself 3 times. This is just a quick brain processing speed test to show how easily our brains can become overloaded. So you can say this silently in your head 3 times to yourself. I'm going to give you just a few seconds to do that. And now we're going to do it again. So read the slides a few times in your head. So maybe you're all superstars and you could pronounce green even though it's red, but our brains can very quickly be overloaded when just a small portion of something changes during a task that we're completing. So why does conversation matters? Well, 3/4 of the educational workforce and a large portion of the professional workforce in Canada are women. So this means that perimenopause and menopause are not just niche issues, it's a workforce reality in our work every single day. And peak career often meets peak hormonal changes. So many women are actually entering their most experienced, leadership heavy years, mentoring staff, running departments, supporting complex classrooms. At the exact same time, their brain chemistry is changing. We talk about hot flashes, we joke about night sweats. Right now, I already want to take off my blazer. But what women often find far more frightening is the cognitive impact, brain fog, word finding problems, and losing their train of thought mid lesson. What happens to me is I actually can do my job perfectly well in the day, and then I come home and everything falls apart. I actually have to remind myself 10 times to perform the same simple task. This also occurs at a time that might hit professional confidence. So you're a highly skilled professional with 20 years of work experience and suddenly struggling to remember a name or a word you've said 1,000 times just suddenly is more difficult. And in the workforce, where perimenopause and menopause affect the majority of women at some point, fewer than 1 in 5 women say they've actually ever experienced any education about cognitive changes that can happen. And when we don't talk about this, experienced professionals sometimes assume something is actually wrong with them. They're burning out, they're losing their edge, or they're no longer performing at the level that they expect of themselves. So, what we're going to chat today together tonight is how these hormonal transitions in our life actually affect our cognition, our communication, and quite frankly, our stamina. So, which changes are expected and when we should actually be more worried. Why sleep is so important, and how, if it's disrupted, it amplifies brain fog and emotional sensitivity and reactivity, and how over time that cognitive load can affect our work, our family, and our relationships. And then we're going to discuss how we can protect our brain health now while reducing the long-term neurological risk. So hormonal transitions, they are brain events. So I think it's important that we do a necessary reframe. The brain actually does run on hormones. One thing we often forget is that hormones don't just affect the body, they're also powerful brain chemicals. Estrogen, in particular, produced by our ovaries, helps our brain cells communicate efficiently with each other. So, across a lifespan, women's brains actually go through several major hormonal shifts: puberty, pregnancy and postpartum, perimenopause, and menopause. Each of these single transitions asks our brain to recalibrate. So, the way somebody told me to think about it once, it's a helpful way to think about it like a software update on your computer. So, the system still works, but while the update is happening, things start to run a little slower. Processing feels less smooth, and sometimes you actually just need a restart. Each transition affects the following things, and we're going to dive into each one of them. So let's talk about neural efficiency. This actually refers to how efficiently our brain cells communicate with each other. When estrogen levels fluctuate, so either during the menstrual cycle or pregnancy or in menopause, those communication pathways, they actually become less efficient for a period of time. And that's why people sometimes feel mentally slower or actually more effortful. Cognitive processing. So, this is how quickly we actually take in information. We think through it and we respond. During hormonal transition, some women note that it actually takes longer to retrieve words, recall information, or actually switch between tasks. Emotional regulation might speak for itself, but hormones greatly influence the brain and how we manage stress and emotions. When hormones fluctuate, people may feel more sensitive, they might feel more angry, they cannot respond to stress in the same way, or they might actually perceive that their emotions are more intense. And finally, communication capacity. This is particularly important in professions like teaching, word finding, staying on track during conversations, and organizing thoughts while speaking all rely on our brain systems that are influenced by hormones. The important thing to remember, this is not a loss of intelligence or ability. This is a temporary shift in how efficiently the brain is actually processing information during hormonal transitions. So hormones, as I said, are regulators of cognitive performance. Our hormones are actually neuroactive. The key hormones being estrogen and progesterone, which are produced by our ovaries, and testosterone, which is actually produced by our adrenals. So they are responsible for influencing synaptic plasticity, neurotransmitter balance, cerebral blood flow, and brain glucose metabolism. So let's unpack those things. Synaptic plasticity, this is actually a scientific way of describing how brain cells connect and share information. Estrogen actually helps strengthen those connections, and that supports memory and learning. Neurotransmitter balance. So, neurotransmitters are basically our messaging chemicals. Some of you might have heard of serotonin and dopamine, which are actually responsible when in fluctuation for producing anxiety and depression. They generally affect mood, focus, and motivation, and hormones actually help keep these systems balanced. When we talk about cerebral blood flow, well, estrogen and progesterone, they also influence how much blood and therefore actually how much oxygen reaches the brain. Good blood flow actually helps keep the brain alert and functioning well. And then brain glucose metabolism. The brain uses sugar just like all other organs in our body, and that's its main source of energy. So estrogen actually helps the brain use that energy efficiently. When the hormones start to fluctuate, our focus drops. So it might become actually harder to concentrate, especially when you have distractions. Processing may actually feel slow. So thinking may feel a little slower, or you're actually putting more effort into thinking than you used to. And finally, I keep coming back to word retrieval, but it happens to me all the time. That tip of a tongue feeling becomes more and more common. You know the word, but it takes a few seconds to actually remember what it is. So the other parts of our cognitive domains that are most affected are our attention. I don't know if anyone's seen the little social media clip where a perimenopausal woman actually belts herself to the dishwasher so she remembers to empty it while she distracts herself by doing a number of other tasks. We've talked about processing speed. We've talked about memory. And then just verbal fluency under pressure. So you might have been able to handle a meeting and talk very clearly for the last 2 decades, and then all of a sudden that becomes a little bit more tricky, and you feel you have to put much more prep work into it. So the important thing is to remember that our capacity remains. Our brain is essentially trying to run the same task, but with a slightly different fuel supply. This cognitive performance actually can affect women all across the lifestyle stages. So during our reproductive year, most of us have a strong baseline cognition, but some early hormone sensitivity can show up. For example, people might have cyclical brain fog, cyclical anxiety, cyclical depression. During perimenopause, and by perimenopause, I mean that transition to the menopausal years, estrogen starts to fluctuate, and this really disrupts the neural signaling. This reduces our mental stamina, it causes fatigue, and a greater effort is actually required for communication. One thing that's really important to note is that perimenopause for some women can last a decade. I can't tell you how many times someone comes into my office and says, I just don't feel like myself. They can't necessarily put the word or explain what they're feeling, but a lot of this is this cognitive disruption that's happening during this perimenopausal phase. The important thing to remember that this is actually our body adapting, and although most of us feel worried about it, it's actually not a decline. It just requires a reset. And then sometimes when we coast into menopause, many of us start to have this brain recalibration and cognitive stabilization over time. Our hormones have started to settle down. So there are cognitive challenges, as I said, across the life stages. Cognitive changes, they don't appear suddenly in midlife. They often reflect lifelong hormonal sensitivity. Some of the common themes that women might express during the various life stages are listed below. So brain fog. So I'll give you an example. You walk into a supply room to get something for your class. You get there and suddenly you can't remember why you came in. You stand there for a second. Why did I come in here? Then a minute later, it comes back to you. So what feels like brain fog, it's often not a loss of knowledge. It's the brain temporarily having a harder time accessing information that is already there. So reduce processing speed. You're in a meeting, someone asks you a question, for example, about a lesson plan or a student situation. You know it very well. You know the answer, but actually takes you a few seconds to organize your thoughts before you respond. Or in my case, sometimes the thoughts just come out in a jumbled manner. And later you are kind of mad at yourself and said, well, I should have said that more clearly. So the brain still knows the answer, but it just sometimes needs a few extra seconds to retrieve that information. And then emotional reactivity. So it's the end of the day, everything's been loud, the emails are piling up, the small issues happen. These normally wouldn't bother you, but suddenly at this life stage, they're starting to feel very overwhelming or frustrating. I can't tell you how many women also say that they experience true rage, and it's a rage that they never had before. So when your hormones shift, the brain's stress response actually becomes more sensitive. So the load hasn't changed, but the brain's capacity to absorb it has. And then when we talk about verbal retrieval difficulty, so you're explaining something, as I said, you suddenly can't find the word. This is really common. So it's just once again taking your brain a longer time to retrieve information that you know very well. And then increased cognitive fatigue, a widely complained about feeling when women come to talk to me. So it's just the feeling at the end of the day, and you're completely drained. So even simple decisions like, what should I feed my kids for dinner, or can I really get to that email? They seem overwhelming. So the brain still can do all the same work, but it's actually burning a lot more energy to get there. So let's explore some of the reproductive fears. So during pregnancy and postpartum, the hormonal shifts are dramatic. So there's a rapid rise in estrogen and progesterone during pregnancy. This changes brain structure related to caregiving and emotional bonding, and it's actually worsened with sleep disruption. Pregnancy brain, it is a real thing. I remember shortly after my son was born, I ordered some food, and for some reason, I decided I had to pay cash, and I could not, for the life of me, calculate the tip. So I just said, take all this money and give me my food. So it's a real thing. And, it's one thing when you're at home with your baby, but then when you have to return to work, that can be an incredibly stressful time as your brain's starting to recalibrate. So common cognitive experiences that women talk about are forgetfulness, that slower word retrieval, definitely issues with multitasking. Women that could do many things in an hour have to write more lists or really reduce the amount of tasks that they're doing at any one time. And then, of course, like heightened emotional sensitivity. Once again, I remember like just bursting out into tears one day, and my husband said, "Is everything okay?" I said, "Oh yeah, it's fine. Baby's just cute. It's fine." But like I couldn't stop crying. And I know it happens to a lot of people. So the brain does change during pregnancy. And once again, these are adaptive functions. They're supposed to happen. They're not pathological or disease states, but they don't feel good. Cognitive efficiency rebounds for most people postpartum, but the key here is that it does actually require some sleep recovery. And for women that aren't able to catch up on sleep, it can lead to some very serious mental health conditions like anxiety, depression, and often not talked about is obsessive compulsive disorder. So in postpartum, the cognitive load really can, burden brain function and lead to identity strain. Postpartum women have fragmented sleep. They're sleeping far less than they need to. They're managing the new emotional labor of a new human in their house. And then they have to return to cognitively demanding roles when they go back to work. And so I would say one of the biggest factors in postpartum brain fog is that it reflects sleep deprivation and the hormones trying to recalibrate. And once again, it's not about reduced ability. The ability is there. Your brain is just needing some time to recalibrate. I'm often amazed when I see people from other countries having their baby in Canada. I often write a letter for them, and they bring over their family members to help take care of them. And that's not necessarily the traditional North American experience. But I think what they're doing is creating a supportive environment, right? That's protecting confidence and then allowing a better performance upon returning to work. And there's actually better job retention when people are with their newborn in a supportive environment, helping to support their cause. So PMDD, this is known as premenstrual dysphoric disorder. Um, a little bit different from PMS, which might just be some emotional disturbances that people feel before their menstrual cycle. PMDD really impacts quality of life. So this is a severe neural hormonal sensitivity to normal cyclical changes. It can affect mood, cognition, and emotional regulation. I have a few people that come to see me because they get completely dissociated during their menstrual cycles. They have to bring their partners with them so that I can explain this to them. So, as I said, this is a severe neurohormonal sensitivity. So, some of the cognitive features might include brain fog, difficulty concentrating, emotional overwhelmed feeling under cognitive load, and really increased interpersonal sensitivity. So, someone that normally feels confident and organized notices 1 week before their period, she feels completely different. So, she might wake up with intense anxiety, struggle to concentrate during a lesson, or feel really overwhelmed by small issues that normally wouldn't bother her. Or a manager performs well at work, but finds that for several days each month she experiences severe low mood and feelings of helplessness. She might actually withdraw from her colleagues, doubt her abilities, and feel really unsure and irritable with her family. And unless someone recognizes this condition, someone might suffer with this their entire life. So PMDD predicts a greater cognitive sensitivity during perimenopause and menopause. So it's actually a signal of how strongly our brain responds to those hormonal fluctuations. And then perimenopause. So this is actually where peak cognitive variability starts to occur. So perimenopause involves very unpredictable fluctuations in our hormones. It's very disruptive to our sleep and actually really increases stress reactivity. All of those things that we talked about are accelerated. So the word finding difficulty, the slower processing speed, the reduced ability to multitask, and that true feeling of fatigue at the end of the day, these are most significant, noticeable, and distressing for women during perimenopause. And then menopause. So, what happens after the transition? Well, actually, because our hormones start to stabilize, the brain is actually adapting to a new steady state, and our cognitive function actually starts to improve. Many women actually report improved clarity, better emotional regulation, and reduced cognitive unpredictability. And some of this actually requires that women receive menopause hormone therapy or other medications to help with that stabilization. So, all this to reassure us that the brain actually is capable of remarkable recalibration, and it's really important to receive medical advice or counseling along the way so that we don't have to wait for the stage before we feel more like ourselves again. So the unifying pattern is that all of these stages, what they have in common across everything that we've discussed, are that cognitive changes actually track hormonal variability. Sleep disruption absolutely magnifies all of those symptoms, and the load actually matters more than the raw intelligence. I've said this a lot. It is not our brain failing. It's really just trying to. I'm going to hand it over to Val.
Great. Thanks, Rami. Hi, everyone. It's so great to be here with you all this evening. So let's talk a little bit about why educators feel these hormonal transitions and these cognitive changes during the hormonal transitions maybe more intensely. So we need to appreciate that educating requires a high cognitive and emotional load. For example, educating involves continuous verbal output. So you're speaking steadily for extended periods of time without breaks. You don't only need to regulate your own emotions, tolerate your own distress, you're also responsible for the emotional regulation of other individuals who may not have the skills or abilities to regulate those emotions on their own. There's high noise and interruption levels, and there's a high decision density. So situations that are mentally crowded with multiple decisions at one time. So you're being asked to make multiple decisions in one given situation. Now, the reason that hormonal transitions will reduce our cognitive margin and make fatigue more visible. So basically what this means is that when we're going through the hormonal transitions during midlife, our brain reserves are less. And so we're going to feel exhausted much more quickly. And so we can appreciate that because of the high cognitive and emotional load that is required with educating, we're going to feel tired much more than we might have earlier in our career because of these transitions and the reduced brain reserves. So in addition to the workplace, we can also feel the impact of hormonal transitions on relationships. So when we think about cognitive load, when our cognitive load is really high, we have a reduced tolerance for interruptions and we have less bandwidth for emotional labor. What this means is that we have less emotional and mental energy to manage other people's feelings. As a result, we tend to withdraw because we don't have the resources to tolerate the interruptions or have the bandwidth for these other people's thoughts or feelings. Unfortunately, that withdrawal can sometimes get misinterpreted as disinterest. And then we have relationship consequences as a result. And so what really we want to take away from this is that many of the relational challenges that women might experience during midlife aren't actually the consequence of the relationship failing in some way or a consequence of our reduced skills or abilities. They're really just the consequence of load challenges. So if we're able to learn strategies for reducing load, for increasing our cognitive health and our cognitive performance, we may also be able to improve our relationships. So we've talked a lot about sleep already and how important sleep is. I'm sure you've all heard that, sleep is the best medicine. Well, why is sleep the best medicine? Because so many good things happen when we sleep. Not only does sleep help our physical health as well as our mental and emotional health, it also helps our cognitive health. So when we sleep, we consolidate memory. We turn new information into more stable, longer-term memory. Sleep also supports emotion regulation. So I always say to people, there's a reason that sleep deprivation is a form of torture. When we are sleep deprived, we are not going to be mentally and emotionally strong. So sleep is so important for regulating our emotions. Sleep supports decision-making. So we are going to be more likely to make or be more efficient and more productive in terms of our decision-making abilities when we sleep well. It's also going to help with verbal fluency. So it's going to be easier for us to find and produce words when we sleep well. As Rami mentioned earlier, many women during perimenopause will report sleep disruptions. So 40 to 60% of women during the menopausal transition report sleep difficulties. So let's talk about why the hormonal changes impact sleep. So when hormonal shifts happen, lots of things will change. And so the hormonal shifts will affect our circadian rhythm. Our circadian rhythm is our body's internal biological clock. So it's basically what sets the timing of sleep for us. Hormonal shifts also affect thermoregulation. We've already talked about hot flashes or night sweats. And so we can appreciate that when we have hot flashes or night sweats, our sleep is going to be impacted. I don't know how many women I've worked with that, have to wake up in the middle of the night and do a full, change of their clothing because they've sweat all the way through their clothing. And so sleep gets impacted because of the hormonal shifts. Rami's also talked about the stress hormone balance. So our body's stress system becomes less steady, which means that we can sometimes feel wired or have difficulty sleeping or trouble sleeping as a result. Hormonal shifts will also affect melatonin production, which is a hormone that plays a crucial role in terms of regulating our sleep. So what does this all mean? What this means is that during midlife, when we're experiencing these hormonal shifts, it could be harder for us to fall asleep. There could be changes in terms of the timing of our sleep. Our sleep could be lighter and more disrupted. Now, although the hormonal transition may be responsible for the onset of our sleep difficulty, so the reason why a sleep difficulty might begin, it's important that we appreciate that there's other factors that might actually maintain the sleep difficulty. So just because hormones start the sleep problem doesn't mean that it's the hormonal transition that's maintaining the sleep problem. So as we can appreciate, when we have difficulty sleeping, we will try to compensate for that loss of sleep by changing our behaviors. So we might choose to sleep in longer. We might choose to nap during the day. We might choose to go to bed earlier to try to make up for the poor night's sleep. And when we continue to have sleep difficulties, we begin to feel anxious and worried about our sleep. So we start to question, how are we going to function the next day if we don't get X number of hours of sleep? And it's these behavioral changes and it's these cognitive changes that can actually serve to reinforce or perpetuate a person's sleep problem. So when we look at helping people with their sleep, yes, we can look at the impact of hormones. So we can look at hormone replacement therapy, but we also need to look at these factors that are perpetuating the sleep problem. So we might need to do something more than just looking at the hormones. All right. We've talked a lot about, the cognitive changes that exist during midlife. So what we can report experiencing when we're going through midlife. What we also need to think about is our long-term brain health. So 2 out of 3 Canadians with dementia are women. And we also know that in terms of key modifiers, these are factors that are going to influence how healthy our brain stays over time, that the duration of estrogen depletion is one of those modifiers. We also know that chronic sleep disruption can impact our long-term brain health, our cardiovascular health, and that chronic stress load. So what we really need to think about is, we've talked about midlife and all of the changes that occur during midlife, but midlife can actually be a really critical prevention window. So if we can learn ways that we can target some of these factors that influence how healthy our brain stays over time, we can actually improve our odds of having more positive long-term brain health. So it's really about, let's change the narrative related to midlife and let's think about it as a critical prevention window, things that we can do to stay healthy and be healthy in the long term. So how do we support our cognitive performance now? What are things that we can do now in midlife? So we can obviously talk about hormone-based approaches. So we know that a lot of the challenges that we experience related to cognitive performance in midlife could be explained by hormonal transitions. And so we can look at hormone-based approaches. A few things that we need to think about when we consider hormone-based approaches is that timing matters. So oftentimes we want to be trying to intervene earlier in terms of the menopausal transition, just so that we can kind of get in there before you have many years of that low estrogen depletion. So timing of the hormone-based approaches are important. Unfortunately, there is no kind of one size fits all. So there is no single best hormone replacement therapy. And so it is about individualized care. The decision is tailored to a person. What are their symptoms? What are their age? How long has it been since they've, been in menopause or time since menopause? Their family history, their medical history. All of these things are going to be taken into consideration. And ultimately, in conjunction or in collaboration with your care team, you're going to do a risk-benefit analysis. So you're going to assess what are the benefits and what are the potential risks so that you can feel like you are making the most informed choice based on your own personal experience.
And Val, I'll just add one thing.
Yeah,
There's
of course.
actually a lot of research right now, just when you talk about using this as a timing opportunity. When you start, for example, if you're someone that's choosing to go on menopause hormone therapy, there's a window that can actually be protective against developing things like Alzheimer's. So I like really just to emphasize your point that timing really can matter.
Yeah, and like you just alluded to, some women don't want to do the hormone-based approaches. And so we do have to also appreciate that hormone-based approaches are individualized in the sense that some people are willing to explore it as a treatment option. Others are less comfortable in terms of exploring it as a treatment option. And so we need to look at other non-hormonal strategies that might be available. So we've talked about the importance of sleep. So if we're able to make changes with sleep, we may be able to see improvements with that cognitive performance. We also know that issues like anxiety and mood, we also know, iron levels, your thyroid functioning, these are all things that are also going to be associated with your cognitive performance and your cognitive functioning. And so we can also target these things from a non-hormonal perspective, and hopefully see changes in terms of the cognitive performance. We can also learn skills and strategies to help with cognitive pacing and load management. So helping people to reduce distractions, helping people learn how to limit multitasking and taking breaks before they become exhausted, having, structured schedules that are optimized based on their abilities. And then maintaining social networks. So maintaining social connections are really important when we think about cognitive health and cognitive performance. So you can appreciate that social interactions are very cognitively stimulating. So when you're engaging in social interactions, you're having lots of opportunities to practice your cognitive skills. We might think that, oh, well, that might take up our resources because they are so cognitive stimulating, but we also have to look at the buffering aspect that they have when it comes to stress. So for a lot of people, relationships are refueling, or social connections are refueling opportunities for them. So they'll lower chronic stress, they'll reduce loneliness, and ultimately improve that emotional resilience. So a couple of options in terms of either the hormone-based approaches or the non-hormonal based approaches in terms of supporting our cognitive performance now. So in terms of non-hormonal strategies, cognitive behavioral therapy is probably one of the most well-researched interventions for targeting some of those areas that we've discussed. So what is cognitive behavioral therapy? It is a structured skills-based treatment, and it focuses specifically on the interaction between the way we think, the way we feel, and the way we behave. So the whole idea is that in any given situation, we have these different components. We have our thinking component, our feeling component, which consists of our emotions and our physiology, and we have our behavioral component. All of these components are bidirectionally related. So the way a person feels in a situation will be influenced by the way they think and behave. The way they think will be influenced by how they feel and behave, and the way they behave will be influenced by how they think and how they feel. As the name implies, what we do in cognitive behavioral therapy is we help people learn about how they think, change the ways that they think. We help people learn about their behaviors and change the way that they behave so that they can indirectly change the way that they feel. CBT is not positive thinking. We aren't simply taking, negative thoughts that people have about themselves, other people, and the world and replacing them with positive thoughts. It's about balanced thinking. It's about increasing one's cognitive flexibility and giving them practical strategies so that they can retrain their brains. So how does this help during hormonal transitions? How does this help during midlife? So learning these strategies can help reduce cognitive overload. So it can help people, it kind of makes thinking tasks feel less overwhelming. They don't feel so overwhelmed when they're trying to make decisions. It can improve our work-life balance. It can improve our emotional regulation. So learning skills for tolerating just stress, but also for regulating your emotions, supporting sleep and stress resilience, and enhancing our executive function under pressure. So, it's one thing to be able to perform well when you're not under pressure, but you can appreciate when educating, you're going to feel like you're under pressure all of the time. And so you really need to be able to think clearly, stay organized, make good decisions when you're feeling that heightened level of stress. Like I mentioned earlier, CBT is a very well-researched intervention, and it's found to be effective for many different areas or many different concerns. So we have lots of research to suggest that for perimenopausal and menopausal women, CBT can improve sleep efficiency and reduce insomnia. We also know that CBT can reduce anxiety, depressive symptoms, and perceived cognitive difficulty. I want to just highlight the perceived cognitive difficulty. So the thing that's important to note is that if we feel like we are more capable, so if we feel like our abilities are better, we're going to feel more confident and we're going to feel more distressed. So we don't actually need to do a test to say, is your cognitive has your cognitive ability changed from X to Y, or has it improved in this way or that way? If your perception of the difficulty has improved, it's going to be very helpful for you. You're going to feel more confident in the tasks that you're doing, but you're also going to feel less distressed about those challenges. These benefits have been found to be sustained over time, and there's no medication side effects. So when we think about pharmacological or medication and we compare it against cognitive behavioral therapy, oftentimes the research suggests that both modes of treatment can be effective for alleviating problems for people or alleviating symptoms. Where there tends to be difference has to do with relapse. And so the reason that there tends to be differences here is because with medication, we're treating the symptom, but when we take the medication away, if the symptom comes back, we don't have anything to help that symptom unless you put the medication back in. Whereas with CBT, it's a skills-based treatment. So if a person learns the skills or the strategies and they stop treatment, if their symptoms come back, they always have that toolbox that they can fall back on. And I always say to people, it is much easier to relearn a skill than it is to learn it for the first time. And so this is how CBT can help prevent against relapse in the long term. Oh, sorry, I did not switch my slide. All right. So let's talk a little bit about the supportive environments. We talked about this earlier when we were talking about the postpartum period, and having those supportive environments help to protect against our help to protect our mental and emotional and cognitive well-being. The same thing can be said for workplaces. So if we know that educating is associated with high cognitive and emotional loads, then we can try to manipulate the workplace environment to help protect that cognitive performance. So this could include things like reduced unnecessary multitasking, predictable schedules, quiet recovery spaces, flexibility without stigma or without judgment, and then reducing stress and also providing emotional support. So like Rami had mentioned before, for a lot of women, we don't necessarily know why things are happening. We don't feel like ourselves. And if we can structure an environment that supports the information that we already know, then people can feel like their best selves in this environment. We can protect their performance and their retention, and we can also protect their mental and emotional well-being. All right, so what does this mean about midlife cognition? We're kind of, hammering home this idea. You're not losing your capability. Your brain is adapting to new biological conditions. So what this means is that when we support sleep, when we reduce chronic overload, when we refuel ourselves by prioritizing pleasure and self-care activities, when we address that hormonal and cognitive health early, we are protecting our cognitive clarity. We are allowing ourselves to be clear, sharp thinkers. We are protecting our career longevity, our relationship resilience. This is the ability of a relationship to stay strong and adapt over time. And we're protecting that long-term brain health. I can't say this enough. We need to change the narrative. Midlife is not decline. It's the most powerful intervention window that we have. Let's learn the skills and strategies, and let's become better selves, or let's become our best selves. So when to seek support. So we talk a lot with people about like what's normal and what isn't normal. So some of these changes are to be expected, but when should I actually seek out support? So when we think about seeking out support, we want to think about a few things. So first, you want to think about, the frequency, the intensity, and the duration of your symptoms. So when the frequency is high, when the intensity is high, when the duration is long, you may want to seek out support. We also want to consider impairment and dysfunction. And what this means is if the symptoms bother you, if you're feeling distressed by your symptoms, or if the symptoms are interfering or affecting areas of your life, work, home, social, other important areas of your life, then it might be time to seek out support. So when cognitive symptoms persist, when your sleep disruption is chronic, when those work or relationships are affected, it may be time to seek out support. And we can frame support in different ways. So we can frame it as optimization. So make something work as well as possible. Let's improve our performance. We can frame it as prevention. Let's stop a problem before it happens. Let's reduce risk. We can frame it as sustainability. Let's make something workable over a long term without burnout. Let's make something last. I'm going to turn it over to Rami to talk a little bit more about how we can support our cognitive
So key treatment options are really aligned with the Canadian guidelines. So as you can see, there's a lot of complexity to what we're talking about. Cognitive health is really multi-layered, and so is effective care. So when I'm listening to Val, I'm learning so much from her lens as far as it relates to CBT. So I can really see how that multidisciplinary approach is really important. So I think there's a couple of key messages from the Canadian clinical guidelines. So first of all, they emphasize that cognitive symptoms during hormonal transitions, they're real, they're common, and they're biologically mediated. And so they're best addressed through an individual multimodal care. So there's I would say, four evidence-based pillars to cognitive support. So when appropriate, menopause hormone therapy can be a key supporter in this cognitive window. And for some women that are not going through perimenopause and menopause, we do use something like the birth control pill or other hormones to mitigate symptoms of things like PMDD that we talked about before, or cyclical depression and anxiety. Psychological therapies, as Val has outlined, are critically important. And then we're going to talk briefly in a short while about some targeted medical treatment of certain contributors. So if anxiety is a contributor or low in iron is a contributor to some of these cognitive issues, then we need some targeted medical treatment as well. And then we need that holistic approach. We need fitness, we need sleep, we need lifestyle foundations. So this is a guideline aligned principle that there's no single intervention that fits all, that we often need to approach it from multiple lenses. So what actually helps the brain? So hormonal support, we talked about it when it's appropriate. So both the Canadian and the international menopause guidelines recognize that hormonal therapy may improve cognitive symptoms related to menopause. And this is really emphasized when the symptoms are linked to sleep deprivation or disruption, and then those vasomotor symptoms like hot flushes or night sweats, or when mood is interplaying here. The benefits are probably most optimal when therapy is individually prescribed. So just like Val said, it's not a one size fits all. Some people can walk into their physician or nurse practitioner's office and get a prescription, be happy, be on their way. But there are a lot of people that I work with, and we have to find the right recipe, what works for them. And then we have both talked about timing. So there does seem to be this critical window where if we start menopause hormone therapy, it's going to offer the greatest cognitive support. And there's now some really good research that indicates that it can be protective against Alzheimer's as well long term for those that might have a predisposition. And then also key, we regularly have to review risk and benefit. Nothing is risk-free. There can be some complications. And after a certain duration, you might have to change your therapy or discontinue it. So hormone therapy, it's not a cognitive enhancer. I would say that it more, supports brain efficiency by creating a really good hormonal environment.
All right. So in addition to some of the pharmacological approaches, I'm sorry, I thought I was on mute there. We can also talk about the psychological approaches. So in terms of the Canadian guidelines for insomnia, mood, and menopause, CBT is actually recommended as a first line or adjunctive treatment for many problems that people report experiencing. So because it doesn't have those negative side effects that sometimes medications come along with, there's a lot of clients that I work with who actually have a personal preference to not take medications. CBT is a really great option for many individuals. So it's considered a first line or adjunctive treatment for chronic insomnia, anxiety and depressive symptoms, and stress related cognitive complaints. So thinking problems that people notice when stress makes their brain feel overloaded or tired. So poor focus, mental fog, forgetfulness, these are all things that CBT can help with. It is highly researched, and there's lots of good data to show that it improves sleep efficiency. It reduces perceived cognitive ability. So like I was talking about before, it's more important about like the perception of the difficulty versus actually assessing to what degree does the difficulty get better over the course of treatment. It's more about that perception, that believability that you might not have the cognitive difficulty, or it doesn't impact you to the same degree that you thought it did at the start of treatment. And of course, it can improve emotional regulation and resilience under load. So the thing that's really important here and makes CBT a little bit different when we're looking at midlife and the cognitive piece compared to other times in our life is that a lot of the skills and strategies are things that we have to talk about when we're under load, because many of us do have those high cognitive and emotional loads at this time in our life. You know, you hear of midlife being talked about as like the sandwich kind of age or generation, where you not only are you caretaking for your kids, you're caretaking for your parents as well, right? And so we have these heavy loads. And so we need to learn skills that will help us when we're under these loads. So overall, CBT does support cognitive health. It helps to reduce mental noise, physiological stress, and it allows the brain to function more efficiently. So there's many skills and strategies that do help with some of the cognitive strategies that we have already discussed today. So, you know, when you think about symptoms of ADHD, there's lots of CBT skills and strategies that target those symptoms specifically that can also be applied to some of the cognitive difficulties that we experience during midlife.
So, oh, sorry, I just jumped ahead there. I'll go back. So when we talk about some of the targeted treatment, we do have to consider things. So Canadian guidelines also emphasize not only identifying, but treating anything that's a modifiable contributor that might be really reducing the optimizing of our cognitive symptoms. So when we talk about chronic insomnia, we know that even 1 week of poor sleep can actually reduce attention and memory, as much as being mildly sleep deprived. And many perimenopausal and menopausal women are losing night after night of sleep. Depression and anxiety, so they don't just affect mood, they can significantly slow thinking, concentration, and memory. And iron deficiency, I know we've given you a number of take-home messages, but I want everybody to make sure that they've had their iron measured. Iron is a super molecule. It carries oxygen to the brain. So when the levels are low, the brain can literally feel like it's running on low fuel. And then thyroid dysfunction, a very common endocrinology disorder. The thyroid is actually a metabolic thermostat. So when it's off, people can experience fatigue, brain fog, slow thinking. So really important also to have your thyroid checked. And then interestingly enough, I know we talk a lot about ADHD in children, but for women, perimenopausal time frame is actually the first time lifelong ADHD traits can actually become very obvious. And this is because estrogen normally helps support and maintain attention and executive function. So as it's fluctuating, those ADHD symptoms might actually become unmasked. So treating underlying conditions can often lead to significant cognitive improvement without assuming that it's actually primary brain disease.
All right. So we have already talked about pharmacological treatments. We've talked about psychological treatments. Now we just need to think about, you know, regular kind of lifestyle changes and things that we can do to help ourselves in terms of our cognitive health. So Canadian Public Health and Neurology Guidance consistently show that participation in regular aerobic exercise will support brain blood flow and neuroplasticity. So this is your brain's ability to adapt and change over time. They've also shown that strength training improves our metabolic and vascular health, which, like we've already talked about earlier in tonight's presentation, will protect cognition. And sleep optimization is foundational for our memory consolidation, emotional regulation, and communication. So what this means is that, we need to exercise regularly. We need to, tap into those sleep hygiene practices, try to improve our sleep. And these other general lifestyle changes can be helpful. They are not optional add-ons. They're core components of our brain health across our lifespan. They're things that we need to be doing day in and day out and prioritizing as part of our care regime. So what is the bottom line takeaway when it comes to cognitive health and when it comes to, trying to intervene in terms of our cognitive health? Canadian guidelines support a proactive, personalized approach to cognitive health during hormonal transitions that's focused on stabilization, prevention, and long-term brain health, not pushing through. What this means is that you don't have to keep pushing through. You don't have to put your head down and keep going. There's things that you can do to help yourself and bring your best self to the table. So in summary, what have we talked about this evening? We've talked about hormonal transitions as being predictable. They're things that we know are going to happen. We've talked about cognitive changes as being common and biological. So cognitive changes are associated with hormonal transitions, and hormonal transitions are predictable. So we can expect that the cognitive changes may occur. Early support changes long-term outcomes. So there's things that you can do. There's things that are within your control that you can do to help yourself. And brain-informed care belongs in the workplace. So menopause-related brain fog and cognitive changes are real. They should be understood and they should be accommodated in our workplace. Thank you so much for listening this evening. I'm going to turn it back over to Lori, and she's going to take over for the Q&A.
Thank you so much, Val. Thank you both so much. I really feel that although, I work with you on a daily basis, I am sitting here leaning in, listening, and learning from both of you. So that was a fantastic wealth of expert information. Very much appreciated. Okay, so one quick housekeeping item before we dive into the Q&A section. So there's a QR code on the screen. It is for the survey that I mentioned at the top of the hour. So if everyone could please take a minute to just scan the code and complete the short survey that you access through that code, we would very much appreciate it. Would really love to hear your feedback on today's session, the content that you received, as well as, any ideas or suggestions for future topics. So thank you very much for that. Okay, we're going to dive into questions. We have a number of questions that have come in throughout the session, and so I will jump to those in a moment. I'm just going to start with a few of the questions that we received in advance. So some of these may feel a tiny bit overlapping from some of the information that you both shared tonight. But let's take them away regardless, because I do think even the recap is helpful. So first question is, can the impact of menopause on mental efficiency be reversed? So maybe Val, I'll start with you, and then Rami, if you want to add, we can turn to you as well.
Sure. So I think one thing that we want to think about with this question is, what Rami had talked about in terms of the different cognitive changes that occur, across the lifespan. So the changes that we experience during midlife are temporary. So, when the hormones recalibrate during menopause or postmenopause, oftentimes people do see improvements in terms of their cognitive functioning, or some of the cognitive functioning challenges won't seem as prominent at that time. But what this means is, you don't have to wait until that time in order to have the difficulties get better or to have the difficulties be less impactful. There's lots of things that we can do during midlife um, to be able to help individuals. Rami, do you have anything else to add?
I think you summed it like perfectly.
Okay, great. I'm going to jump into two quick ones here for you, Rami. So, first is at what age does perimenopause end? And the second is how long after your period stops are you in the stage of menopause? I think the two can go hand in hand. So,
That's the question Lori and I get a lot. So perimenopause, it is, as we say, that window where your hormones are starting to fluctuate. It can begin for some women in their late 30s, for many women, early 40s to mid 40s. Everyone's a little bit different. For some women, they might have very few symptoms, and for some women, it might last for up to a decade. The actual definition of menopause is 12 months without a period. My advice to anybody that's having a lot of distress with their symptoms, and if you're feeling dismissed by a healthcare provider because they tell you you cannot have treatment because you're not in menopause yet, that person does not have a deep expertise in how much the symptoms of perimenopause can affect someone's quality of life. And that's actually a really good window for some women to start menopause hormone therapy, other medications, or make various lifestyle adjustments.
okay, excellent. Next question. How can I manage interpersonal relationships when my mental load is extremely high? Val, maybe I'll go to you.
Sure,
One.
sure. So I think the big thing is whenever we think about relationships, we want to communicate. And so for people who are in relationships with men, men are not women, they cannot appreciate what it feels like to go through the menopausal transition. And so communicating and being forthright with your experience can help. Also, I think Rami had shared an example where a spouse had actually joined an appointment to learn more about the person's experience. So, if you are seeking out support, whether it be from your doctor, whether it be from, another healthcare provider like a psychologist, a naturopathic doctor, a nutritionist, or a dietitian, bring your spouse along. They can talk to them about the experience and they can educate them. I think the other thing that we want to think about is, when we think about load, we also want to think about what are things that are within our control that can reduce the load. And so one of the things that is really important that many of us don't do during midlife because we put everybody else's needs above our own is we really need to carve out that self-care time, that time for us to refuel, for us to recharge. So when our load is really high and we don't give ourselves the opportunity to refuel or recharge, it's kind of like we're trying to run on empty. Like we need to stop at the gas station and put some fuel in our tank. And so in terms of the interpersonal piece, I think one, we want to be forthright and we want to be communicative about our experiences, but we also want to focus in on ourselves as well. So we don't necessarily want to go right after oh, we need to do something together to improve our relationship. Sometimes doing things to improve ourselves and change our own experiences can influence another person because we are dynamic beings. So what we do differently is going to influence the way somebody interacts with us. Rami, do you have anything else to add?
Nope, that was perfect.
Okay, I'm going to go to the next question. I promise you this is not my question, but it could be my question. So the question is forgetfulness during menopause normal? I would almost reframe this to say, please tell me that forgetfulness during menopause is normal. And how can I tell the difference between hormonal changes and something potentially more serious?
Yeah, so
Question.
this is incredibly common.
Mhm.
And I find is actually a lot of people can go about their job perfectly well, but the forgetfulness kind of stumbles in when they're at home, right? Or trying to do other things. There's only so much room in the filing cabinet. So first of all, I think it's important that most cognitive symptoms are benign and reversible. And that's especially the case when sleep, mood, and hormonal changes are at play. But sometimes it can be important to discuss things with a clinician, and things that might signal that we're dealing with something a little bit more serious or something we can't entirely blame on hormone fluctuations. So more consistent or progressive memory loss, so not just the occasional. Um, Really significant difficulty performing very familiar tasks, getting lost in familiar places, and then if personality or behavioral changes. So I've actually had a few people come to me because their partners have pointed out like quite significant personality or behavioral changes, and they might be signals of other early neurological conditions. Or sometimes they're less serious things like thyroid, vitamin deficiencies, or it also can be mental health. So I would say, all this to say if they're more progressive and more challenging rather than just, forgetting something, losing track of time, a little bit of difficulty concentrating when you're stressed.
Okay, next question. Are eye issues or eye changes and headaches common during perimenopause? Rami.
My number one personal frustration are my eyes. So I need to see all kinds of distances during the day. I need to be close up. I need to be far away. I need to read. And eye fluctuations in menopause and perimenopause are incredibly common. Make sure you get to a good optometrist to do a really good evaluation. It's key. So definitely the eyes. I used to laugh at my colleagues who walked around with three glasses. I am
Mhm.
at that point. The next thing is headaches. So there are a number of different types of headaches, tension headaches, for example, and then migraines. Migraines, we could do a whole talk on migraines as well. They are intimately related to all of these hormonal transitions we've been talking about today: pregnancy, postpartum, menstrual migraines, perimenopause, and menopause. So incredibly common, incredibly difficult to treat. And Lori and I just learned that they're actually the third most common reason that women miss work. And they can change. So the symptoms can change quite significantly. So getting a good migraine evaluation is key. As some women in perimenopause and menopause, they can become quite debilitating during that time.
Okay, next question. How long is it safe to be on hormone replacement?
That is a very good question and a very common question.
Hmm.
So there's a few things. I have three groups of people that come to see me. So some people come and they go on it for a very short window and then they come off. And then the most common window is the window that is sort of recommended by the Menopause Society, which is a 3 to 5 year window. Um, but that is a guideline. It is not an absolute rule, and there's a lot of flexibility in that. My third window are my lifers. These women are never coming off hormones. I have women in hormones in their 80s because it makes them feel better, and they know that. And coming off of it has never been a good thing for them. All this to say, I think it's really important to constantly and consistently work with a menopause hormone therapy provider to have discussions about what your ideal timing is, what your ideal regimen is, and when might be a good time for you to stop taking those medications.
Okay, so this one is for you, Val. So the question is, you used the words OCD in the beginning of the presentation. Could you please elaborate and give some more information about this?
Sure. I didn't actually use the words. I think Rami used it when you were talking about postpartum. But OCD stands for obsessive compulsive disorder. So it is a mental health condition that people can report experiencing. Basically, it consists of intrusive thoughts and or compulsive behaviors. So you don't actually have to have both. You can have one or the other in order to meet criteria. Because we're talking about hormonal transitions, I think one of the things that's interesting to talk about with OCD is I actually see a lot of women who first become diagnosed with OCD in the postpartum period. And it's not that they haven't had symptoms of OCD before postpartum, but one of the common things that can happen is we all experience intrusive thoughts. And all parents experience intrusive thoughts related to their children. But when the content of an intrusive thought shifts to being about a baby, so like a common intrusive thought that somebody during a postpartum experience might have is, walking down the stairs and having the intrusive thought of falling down the stairs while holding baby. This becomes really scary for some people. And the way that they make sense of that experience causes them distress, and then they engage in behaviors in response to it. So I think what's important to think about with OCD is there's lots of myths and misconceptions that people have about it. It is a very treatable condition. Many people that I work with have a lot of fear of being diagnosed with OCD, because they come to me and they tell me that I've heard that it's not treatable. Well, there's lots of things that we can do to treat it. We can treat it with medication. We can also treat it with cognitive behavioral therapy. Um, so highly treatable, but also something that many women aren't even aware of until they're in the postpartum period.
I would also say some women feel great shame, and so like because of those thoughts, and so
Yeah,
likely to reach out for help, because they don't want to share what they're thinking about or the thoughts that have, been present for them.
yeah.
Mhm. Okay, next question. Some aspects that make my workday busy and stimulating are unavoidable. I think this is probably, very common for many working women. Are there things that I can do outside of reducing work stress or strain to reduce the impact of menopause? I think probably both of you could take this one or add two.
Yeah.
So, Rami, I'll start with you.
I was going to learn from Val, actually. Can I
I'll let you go first and then I'll pick up.
Well, the bottom line is we all have certain realities of the demands of our job. So, I think even attending talks like this and workplaces allowing us to present these topics, that's a really first step to acknowledging that this is an important experience that women have. There's some really practical things you can do during the workday. Go out for a little walk, take a 5-minute break. I mean, there's lots of things like that. Eat properly. Like, I can't emphasize that enough. Sometimes I get up, I make everyone in the house lunch, and then I go to work and realize I have nothing. So, it's all goes back to taking care of yourself. And then, if you're experiencing some of the perimenopausal symptoms, or you're not sleeping, sometimes really just introducing some medical therapies can help on that end while you're trying to make some of the lifestyle changes as well.
Yeah, and I think I would just add, I think a lot of it has to do with some of those other kind of lifestyle changes that we were talking about. So, you might not be able to manipulate a lot of things within your work environment. I do agree with Rami. I think there are probably very small changes that you could make that would be very meaningful over time. But that being said, there's lots of positive things that we can do outside of work that are going to help reduce our cognitive load. So even if you think about the exercise piece, we've talked about the benefits of aerobic exercise, the benefits of strength training. So, outside of work, trying to prioritize or reintroduce movement and exercise into your life. We've talked about the benefits of social connection. This is a big thing that can help refuel and recharge us. It can also help protect that long-term brain health. So, being proactive, being intentional, scheduling time to do things outside of work can obviously help with the load that you might be feeling at work. Yeah, and like Rami also said, like diet is so important. The foods that you choose to fuel your body are going to be really important in terms of the energy and the resources that you have. So although you might feel like your hands are tied in terms of some aspects as it relates to work, lots of really good things that you can do outside of work that will have an influence for you when you're in that work environment.
Excellent. Okay, I'm going to take a question that this individual indicated. I don't know if this is a silly question. I do just want to say there's no bad questions whatsoever, no silly questions. So the question is, how do you actually know if you're in perimenopause? So Rami, I'll let you take that one.
That is not a silly question. It's actually an excellent question. And I would say it twofold. So, one is I said earlier in the presentation, I can't tell you how often women come to me and say, I just don't feel like myself. So, you might actually have to talk through it with a healthcare provider who will do an evaluation of the symptoms that you're experiencing. The most common thing being the fluctuation of your periods, and then all those other things that we talked about set in, the hot flushes, night sweats, sleep disturbances. That's not to say other things might be causing those symptoms, but it's incredibly common. If you're experiencing a range of those symptoms and there are over 40, you're likely to be in perimenopause. The second key thing I talked about in this presentation is I cannot tell you how many women are dismissed by healthcare providers who do not have a deep level of expertise in perimenopause and menopause. Women will often be told, I'm sorry, you're still having your periods. There's no way this is menopause. And so they don't get the treatment that they require. And so women often have to be their own health advocates. They have to go doctor to doctor, seek other allied health. And that's really very difficult in our modern system where there's not a lot of family physicians, and the wait lists for specialists are very long. So if any of these symptoms are resonating with you and it seems age appropriate, it's highly likely that you're experiencing perimenopause.
Yeah, and I will share. I know if you've been on previous sessions with us, you may have heard Rami or I talk about our personal experience as well. I will share. I was 42 when my perimenopause journey began. I had a fantastic family doctor, but I went back multiple times to him and was quite dismissed. I myself didn't think I could be anywhere near menopause because I was, only in my early 40s. And I think to Rami's point, it is just so important to trust yourself, know yourself, and if things that you are experiencing do not feel normal to you, keep pressing, right? Keep pressing forward and look for the support that you need. It really is one of the main reasons that we began June Health together is because we feel like women should have just better direct access to qualified women's health specialists that listen to them, really empathetically and expertly understand their needs and provide good treatment and support. Women deserve that type of support. So that is my 2 cents on this topic as well. So, next question, is continuing to take birth control an acceptable option for hormone therapy?
Definitely for a lot of women, it is. So many women will coast well into their menopausal years, still on a combined birth control pill. As long as it's controlling your symptoms, it's perfectly acceptable. Once again, you might want to touch point with a healthcare professional to make sure you haven't developed new risks. There are some different risks depending on your medical condition or certain lifestyle factors that might be different from the birth control pill rather than menopause hormone therapy. The other thing is if you've ever been told you can't go on the birth control pill for certain reasons, that might not necessarily mean that you cannot go on menopause hormone therapy. So just important to have a good discussion with the experienced healthcare provider.
We have a few questions here that relate to being in, your 60s or 70s and still having symptoms. So hot flashes, night sweats, etc. Is there, a window for which hormone therapy or other type of treatments, sort of end or no longer make sense?
Yeah, that's kind of a layered question. So, if someone's still having symptoms and they're not controlled on medication, it just makes me think about a few things. So, one, do we have the dosing and delivery right? Do we have to add something else? So, for example, we sometimes use medications that are used to treat depression, can also be used to treat menopausal symptoms. But we also don't want to blame everything on perimenopause and menopause. I mentioned earlier, thyroid disease, incredibly common, can cause many of the same symptoms, and that's something you don't want to miss. So if you're having persistent long-term symptoms, it warrants an evaluation. I wouldn't just blame it all on perimenopause and menopause and failed treatment. I would certainly want someone to do a deeper dive.
Okay, next question. For hormone medication, who do we ask? What is the right type of practitioner? A doctor, a naturopath, a nurse practitioner?
So the bottom line is all three can prescribe. I think the key is to find an expert. I also have been monitoring the questions, and yes, it is very overwhelming out there. The Menopause Society actually has directories of menopause experts. If anyone's struggling, we, of course, at June provide comprehensive perimenopause and menopausal care. But yes, it can be quite difficult to advocate for yourself, but general practitioners, obstetrician gynecologists such as myself, nurse practitioners, and naturopaths can all describe various types of hormone replacement therapy.
Okay, excellent. We have a few questions here around CBT as well, Val.
Mhm.
So, do you need a referral to get access to CBT? What is the right type of provider? Can you just provide more information generally around cognitive behavioral therapy?
Yeah, so it really depends on where you're accessing service. So there's a lot of clinicians available in the private sector. So, a private psychology clinic or another private clinic, you can pay a fee for service. If you have extended health benefits, typically extended health benefit providers will provide coverage for work with a psychologist. Sometimes they will provide coverage for work with a social worker or a psychotherapist. You would have to look at your extended health benefit provider to confirm which type of professional um, they do provide coverage for. If you are looking for an OHIP funded CBT option, then you would need a referral because you would need to be referred to a hospital based setting. So there are some hospitals that do offer specific CBT options for women's health concerns. So they do offer it across the board in terms of like PMDD, like Rami was talking about, pregnancy and postpartum, as well as the menopausal transition. But you do need a referral in order to seek out those services. But you don't need a referral if you're going to a private clinic. So you can just simply call the clinic themselves. Wait lists will vary. Some clinics might have longer wait lists, some clinics might have shorter wait lists. So it's just a matter of trying to find a clinic that you feel like is a good fit. I think I would also kind of echo what Rami had mentioned earlier. You're going to just want to ask some questions and do due diligence. So if a lot of the mental health concerns that you're experiencing are related to the menopausal transition, or you're noticing that you're having difficulties with mental and emotional well-being as it relates to your menstrual cycle, you're just going to want to ensure that the person that you're working with does have some knowledge and some experience in those areas. So, you are entitled to ask questions. You can ask for like a brief consult so you can get a sense of what it is that they offer, just so that you make sure that you are receiving services from somebody who is a good fit, because treatment is a large investment of your time as well as resources. And so it's important that you feel like you're working with somebody who's going to meet your needs.
Excellent. Okay, I'm going to end on one last question. So, any advice for women who are struggling with perimenopause or menopause symptoms at work on really being able to have the conversation with colleagues and or leaders in a comfortable manner so that they're able to get the support that they need in their workplace?
Well, I think starting with a webinar is a great idea because it frames the discussion. I think fortunately perimenopause and menopause is having a moment. So I think those conversations are going to start to get a little bit easier. But I think, delivering education, talking together around education, inviting experts in is all a good way to start the conversation together. Val, I don't know if you have any further advice.
Yeah, I agree. And I think part of it too is really looking at, I always encourage people to try to be as objective as possible when they're having these conversations. So, what is it that what are the symptoms specifically that you're finding challenging? So, if we're looking for accommodations and we're looking for supports, we want to try to be as objective as possible. So, if we're finding that the load in certain areas is really high, or if we're finding that, we're having difficulties with multitasking, being very objective in terms of and direct in terms of what it is that you want support with or you want accommodations with. Obviously, it is going to look different for different people because we all have our own individualized experience, but being as direct as possible, I think, is also helpful.
Okay, thank you both so much. I agree with you, Rami. I think the point that you made just at the top of that question on, really just creating awareness, providing education, and having conversations like the one we're having tonight are really an incredibly important step in the right direction and really do, begin to destigmatize these important conversations around women's health. So I really want to thank OTIP and Member RX for sponsoring this session tonight and making this available to all of the members. I want to thank you, Val and Rami, for all of the great wisdom and expertise, and thank everyone for joining us as well. We encourage you to come back into the portal. A recording will be made available in the OTIP Women's Health portal, which was in your email communication as well. And if you do have a minute to complete the survey and give us your feedback, we very much welcome it. So thank you again, everyone, and have a great night. Stay well.
Thanks for having
Thank you. Take care.